Hi, everyone. My name is Samara Osman. I'm the VP of Research and Public Policy at Muscular Dystrophy Canada. It is with a lot of joy that I present today's webinar and introduce today's webinar. This webinar is called Co-Constructing a Framework for Spinal Muscular Atrophy Rehabilitation. This is a very exciting project that Muscular Dystrophy Canada was able to support as part of one of its research grants. And we're really pleased to have Patricia Mortenson here leading the discussion, but together with patient partners, as well as Dr. Jill Zwicker. Patricia is a fantastic occupational therapist and someone who is undergoing her PhD studies at the University of British Columbia and at BC Children's. We've had the pleasure of working with Patricia on patient engagement and what that looks like. And you can see today she'll probably model excellent patient research engagement. So over to you, Patricia, and thank you so much for agreeing to present on this topic.
Lovely. Thank you so much, Hamira and Muscular Dystrophy Canada, for hosting us today in this webinar. As Hamira said, we will be presenting a project that has been part of my doctoral work. We are looking at how we can co-construct a new framework for how to do spinal muscular atrophy in a time of new treatments and new potential. This work has been a team effort. It's included patient partners who are all co-presenting today with myself, as well as my doctoral committee, Drs. Jill Zwicker and Catherine Bachman, who are OT researchers and professors at University of British Columbia, and Dr. Catherine Selby, who is a pediatric neurologist and neuromuscular specialist at BC Children's Hospital. Just to declare conflicts of interest, Dr. Catherine Selby has been a principal investigator in clinical trials with the following pharmaceutical companies and has received an honorarium for consultant advisory committee work as well. The remaining of us have no conflicts of interest to declare. And before we go further, we are located across many different lands, and patient partner Serenity will give our land acknowledgements for us.
The patient partners, and today I'll be doing our land acknowledgements. We live on many unceded ancestral territories, including the shared territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, as well as the shared territories of the Katsi, Simamu, Kwantlen, and other Coast Salish peoples, shared territories of the Mi'kmaqi and Wabanaki as well, the treaty lands of the Cree, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, Iroquois, Anishinaabe lands are now known as part of Treaty 6, 7, and 8, and the homeland of the Métis people.
Thank you, Serenity. And just to introduce those of us who are actually speaking today, Hamira's already introduced myself as an OT at BC Children's Hospital and doctoral student. Next we have...
Hi, everyone. Thank you for joining us this afternoon. My name is Julie Clegg, and I'm a patient partner on this research project. And I have a son who is 18 years old with SMA type 2. So I have a bit of experience with SMA, and I'm really glad to be here today.
Thank you, Julie. Also online, we have Amneet, and Amneet is a young adult living with SMA and is located in the Fraser Valley, sort of near me in the Lower Mainland of Vancouver. And then next we have...
Hi, I'm Serenity Tremblay. I am also a patient partner on this research project. I am a 20-year-old SMA patient living with type 3 who is currently going to school to be a teacher.
Yay, Serenity. And finally, we have Renelle. Renelle is a young adult living with spinal muscular atrophy as well on the Maritimes, so out on the east coast of Canada. She unfortunately had to be working right now. She's hoping to be live streaming this as we speak, but we've pre-recorded some bits with her as well. So to start with, spinal muscular atrophy is in a really exciting time right now with disease-modifying therapies, we call them DMTs, newborn screening and gene therapies. It's a really exciting time of new hope and new possibilities for children and families. But these treatments aren't a cure, and children still have needs, and rehabilitation is still needed. But we really don't know how to do rehab right now, what's best, when we should be doing it. There's a lot of different questions right now. So to start off with my doctoral work, I did a really big scoping review of the literature. I looked really wide and broadly and over many years, both before and after the new treatments. And I couldn't find any SMA specific rehabilitation frameworks or things that help us guide and plan what rehab should look like. And the standards of care are outdated. They were done before treatments came available. So within the literature, what I found is that there's a disproportionate focus on impairments and not so much on functioning. That there's little multidisciplinary rehab focus, that there's uncertain evidence. We don't actually know what works best and what to do. And most importantly, that the voices of children and families are missing. So what does this mean for current rehab services? Over to Julie.
There are some concerns and questions about current rehabilitation services for children with SMA. Many get too little. Many children and families get too little rehab and support either through lack of services in their area or feeling overwhelmed with their PT/OT schedules and just not doing them. Many get too much. Some children might be getting too much, with every moment of their day being consumed with rehab, leaving little breathing room for other activities in a week. Which wasn't us, as we struggled to make the time for rehab, but we always managed to do something during the day, even if it wasn't on the structured rehab schedule. Are we using the right methods? We don't know if we are using them correctly or the right methods, such as what techniques might work best. Are the current therapy measurements, such as the Hammersmith Functional Motor Scale, even the revised model, is that appropriate in a new era of disease-modifying therapies? And we don't know if we're focusing on the right things for families. There's only so much time and services, so we need to know how to use our time wisely for the most meaningful impact for families and for the child with SMA. And most importantly, we don't know if we are supporting kids having a childhood in the midst of all the medical and rehabilitation treatments. For example, when my son, with the picture on the screen, was little, he spent a lot of time in the stander. And our family is big on functional therapy, making sure that he had fun while not realizing he was in the stander to increase bone density and improve organ functions. So we played with Play-Doh and colored and even baked cookies to ensure that he was having fun while working his muscles. We tried to fit this in on a daily basis, but sometimes that just wasn't always feasible with the many appointments, with his schooling, and of course, with sickness. But after his rod surgery for severe scoliosis, getting into the stander for therapy was difficult, so we took a break for a few months and then started again with a new, more improved and comfortable stander that took a lot of adjustments to become comfortable. By this point, he required a new stander with new and improved features for comfortability. And then
Thanks.
navigating the system, which I have a bit of experience with that, being 18 years old, we've definitely done our time at the pediatric hospital. Would you like to flip the screen?
There we go. Yeah.
Yeah.
Thank you. Thanks, Julie. So what is this project all about, knowing that we have this context? I've got a pre-recorded bit here from Amneet, so just bear with as the recording starts.
The purpose of the study was to co-construct a framework to guide SMA rehabilitation. First, the purpose of work purpose 0. Second, innovation and what changes that can happen, and lastly, what research happens.
Great. Thanks, Amneet. So how we did this is we used two different methods, actually. The first is a qualitative research method called constructivist grounded theory. That's just a lot of words to say that you listen really in-depthly to a range of different voices to develop a deep understanding of processes and experiences. And that's something in this case is the experience of SMA rehabilitation. And we did that embedded in a patient-oriented research approach so that we had patient partners who were part of the data collection and the analysis and sharing of results, as in today. The participants in our study came from coast to coast to coast across Canada, as shown in the red on the map of Canada here. We had one adult living with SMA, 5 children and youth living with SMA, 9 different parents, and 8 rehabilitation professionals and / representative of a patient organization. The blue represents all the males and the yellows all the females. Blue's males. Sorry, no, that's the other way around. The blue, is the females. The yellow is the males. And yet, as we can see, there is a larger proportion of individuals who are male who live with SMA. And as we can also see, there are definitely more females as rehabilitation professionals than males. For the rehab category as well of interest is that all but one were involved in public services with one private therapist as well. We had 2 families that had both a parent and a child participate as individual voices, but that meant combined between our child participants and our parent participants, we had 14 unique children that were represented in this study. 2 of those children had gene therapy. An additional 2 had both gene therapy plus risdiplam, and the remaining 14 had nusinersen or risdiplam treatments. Most children were sitting independently and some were walking. And you'll note that I'm reporting this according to functional terms and not to the traditional type 1, 2, and 3 SMA. With all the new changes and newborn screening, those old cohorts of 1, 2, 3 are now starting to change and it's much more complicated. So we're reporting by function. So how did we get our data? The first method we had was in-depth co-interviews. So we did these on Zoom so that we could get that wide range of participants from across the country. And on almost all the interviews, we had co-interviewers. So it was myself and a patient partner interviewing together. Most interviews lasted about an hour. The youth ones tended to be a little bit shorter. We also had parents and therapists fill out questionnaires. So parents reported on what their child's experiences of rehabilitation services were, what they were doing, etc. And then for professionals, they were reporting on what their experiences of providing SMA rehab were. So how does this all work, the methodology? So once we'd done all the interviews, I did what's called line by line coding. And that's where you go through the transcripts line by line and you describe what the meaning is and you code them. After I had coded about 10 interviews, Julie and I together went through all the codes and interviews to make sure that the quotes that were in a code actually made sense with that code. And also that all the quotes had a home, that they were represented somewhere in all the different codes. Then as a group, we started to clump all those codes together into concepts and then into larger categories. All the while, I was going back to the interviews to make sure that the quotes still fit into the categories and that it all made sense. How this looked in action for the grouping is that we started using an online whiteboard so that we could move things around, move those codes around online, both together present in meetings and individually offline. But we all discovered that we had a preference for things being tangible. So I ended up chopping up codes and mailing things out, and then so that people could sort things out together into different piles and move around. And we had several different Zoom meetings where I had these all spread out on my dining room table, and we talked about where we wanted to move things and shift things and why into different piles and categories. The last thing we did is in a Zoom meeting with an online whiteboard again, is that we started to, with the categories, look at how things were related and how they maybe overlapped and how those categories fit together. And after all of that, what we found is that there were 7 main factors in experiencing SMA rehabilitation today, and that sort of explained the whole process and experience of it. And that when we remixed all that up, we found 4 new ways to re-envision rehab now and into the future. And how this is represented, it is in this beautiful artwork. We can see that the child is in the center, as well as the caregiver, and that they are both have unique experiences of SMA, but of course they are very much entwined and overlapping together as a family. Rehab intersects between that experience as well. Rehab is there to support both the child and the caregivers and the family. But we're all living and working in a time where there's many different changes in SMA, and living with SMA comes with a whole set of experiences as well. And everyone is navigating the system, or systems maybe, which comes with its own experiences. And overarching all of this is a tension between what's expected and what's possible. But as I said, when we re-envisioned that, we came up with 4 different categories. So over the next several slides, we're going to be describing each of these factors in more detail. And we will be using quotes to highlight some of that. The names that we are using are fake names. So to start off with, from the voice of Amni, we're going to be talking about SMA today.
SMA is a time of celebration and hope. When getting diagnosis and treatment and getting to rehab are difficult. We are seeing new types of SMA with different needs, and keeping up with all the changes takes time and energy for families and therapists. It's tricky to know what influence of the SMW treatments and what of the SM rehab. Here we have some quotes from the early interview. This is from Margaret, the therapist. The SM community is very educated and well informed. They stay on top of things, and they're all very excited and optimistic. I think that's fantastic. I didn't work with the optimism because I think that empowers families to do more and be more involved. This next one is from Athena, who was a parent. How do we make sure that we're not leaving anyone behind going forward?
Thanks, Amneet. And the next one, the next category is Renel's voice.
The second factor is honor the child. What we heard from people was that rehabilitation needs to think of the whole child, not just how they move and what their physical skills are. Here's a quote from Mom Molly. I realized his speech. He has a bit of a delay. And then I was asked, do you read him books? But I realized that therapy does take a lot of time, and some things we don't have time. We also heard that children need a say in their rehab and to be supported to become self-advocates. Each rehab plan will look different depending on the interest of the child, such as swimming, playing sports, an instrument, and children need a say in what that looks like and what they want to do. And supporting friendships and community participation is important. It's a good thing to have friends involved so that they can also be a part of your world and not just have rehab be a separate thing all the time. It makes rehab more enjoyable and not a negative thing in your life. Here's a quote from a young person. Independence is making your own decisions, doing things not necessarily by yourself, but doing it with your opinion and nobody else's.
Thanks, Renelle. And over to Julie to talk about caregivers. Oh, here comes Julie. Just a sec. No worries.
Oh my goodness, I'm a mess. Sorry about that.
No worries.
Yes, another factor that we found is consider caregivers. As caregivers, we need care too. We have to balance daily life of having a child with SMA, work, family, and relationships on top of rehabilitation. We heard through questionnaires and interviews with youth, parents, therapists, and caregivers that it's important to consider caregivers in rehabilitation planning. We have to fit it all in. It can be difficult to fit it all in, including rehabilitation appointments and home programs. Doing a good job. It's hard to meet expectations of the system and our own expectations of ourselves that we are doing a good job. Am I doing enough? It's a question that I still ask myself today. And my son is still, he's an adult now, and I'm still asking that question. He's thriving at university, he has a job, he has friends, and he's happy. So I think, yes, I'm doing enough. But then there's that little devil on my shoulder that says, are you doing any stretches? Is he doing his swallowing exercises? Is he getting enough nutrition? And the list goes on. And from one of our interviewees, a parent, Molly, again, not real name, I don't want to not enjoy his childhood because I'm trying to wear those other hats. It's a tricky place to be because there's always this feeling that I could and should be doing more.
Thank you, Julie. Next, we have doing rehab from Serenity.
Yes. And then there's the doing rehab part. We've heard from people that rehab is appreciated. It helps supports parents and families, and it is such a good thing. But therapists often feel uncertain about what's physically safe to try, what techniques work the best, and how to push kids. We hear that focusing on improving motor skills through exercise and stretching and standing programs doesn't always match the goals that youth have and meaning for them to do. It's something I ran into a lot as a youth going through rehabilitation. People also told us that rehab happens in many different places, such as clinics, hospitals. I'm sorry, I lost my place.
No worries, Serenity, you're doing great.
Such as clinics and hospitals, and it doesn't always happen in community spaces. And we've also heard that children often need distractions and strategies to get through their rehab. It's easier to do this when children are young and play games and play work, but as youth, it does get older, and simple distractions don't work, and therapy sessions can be tedious to get through. We have a couple quotes here from Marianne, who's a therapist, and Lewis, who is a youth, saying, knowing what's the best thing to do, what could possibly bring some harm, what can we really tap into? It's really difficult to feel the confidence that I can feel in other areas. And it's really interesting to see another youth afterwards saying trumpet or curling or doing sports also builds strength and builds knowledge of how I can move. It's not formal therapy, but I personally consider therapy. So how can therapists work with what works for children and know that these are things they can do in their everyday life?
Lovely. Thank you, Serenity. And from Amneet's voice, describe what it's like living with SMA.
Living with SMA requires family, parents, and children to adapt to changes in function and manage fatigue, experience disabilities and societal barriers, and can carefully transition to life's different stages because it's a whole new world turning 18 years old. It requires that you focus on being equipped with skills and for living. Here we have a quote from Aaliyah, who's a parent. I kind of focus on letting her know that parts of him that are naturally disordered, that has been disordered, because I can't count on him being able to move around forever, but I can count on him being able to write, make jokes, and see the humor in things.
Thanks, Amneet. And next we have Julie talking about navigating the system.
Yes, and it's my turn to go through navigating the system. Everyone is navigating the system: parents, caregivers, youth, and even therapists. In this research study, we have heard that rehab and health systems are challenging to access for families and sometimes for therapists too. Families often need to do a careful dance and negotiation to access what we need. For us, having a strong support system and a large neuromuscular community to provide resources and help with navigating information and the system has been most helpful. Many families supplement their public rehab services with private rehab, and often at their own expense. For example, when my son was having some swallowing issues due to lack of public services, we chose to seek out a private speech language pathologist and a private ENT, where my son had a scope and then thereafter an exercise program within a few weeks after his public swallow test. Because children with SMA have many different layers of medical and rehab services, we heard throughout the research project that good and clear communication between professionals is really important, and it's extremely helpful for all parties when this just happens without families having to mediate. And finally, what resonated with us is that rehabilitation needs to be a collaborative process between children, therapists, and families. Life in therapy happens so much easier when there's a good understanding of what the goals are and what a family needs. And a quote to highlight some of this is from parent Molly again. It's a really delicate dance, right? Because you don't want to be so squeaky that people start not wanting to help, but also so squeaky that we burn bridges, and that feels like kind of a little bit icky, like a little bit almost political. I don't love that piece.
Thanks, Julie. And then this last factor that we described, that overarching factor of tensions between expectations and potentials. We know that with many unknowns in SMA, it's really difficult for families and therapists to navigate. We don't really know what's expected and what's possible. So if there's expectations are higher than what is actually possible for a child, there can be a lot of stress in the system. Likewise, if you don't have expectations, it's really hard to plan and to achieve something if you don't have expectations. So rehab can sometimes contribute to that stress. If we're pushing too hard and too much, it can really strain that push and that pull on that rope. And likewise, if there isn't enough, it's just too lax. But rehab is done well, it can help support the system in balancing it out. And what we heard from the children, the caregivers, and the therapists that we interviewed is that people had ideas for how to do this. And that is how we came up with these 4 different categories to re-envision rehab for now and the future. And I'll be talking about these in more detail. The first one is to be open for new approaches. So the first thing that came up was to have creativity. That children and youth really valued being able to try new movements and possibilities in their bodies and different functions just for fun, not necessarily tied to all those different assessment measures and tests that they have to do for their treatments, but just to have an opportunity and space to try things out. We heard maybe in the swimming pool, someone told a lovely story about discovering that they could use a pencil sharpener in a new way. That timing is really important to look at, that maybe we should be looking at more therapy when children are younger and backing off and less as they grow and have more complex lives and things they want to do. That we need to look at restructuring rehab. Families really valued intensive bursts of rehab that were really goal focused, but followed by breaks just to allow time to live and to breathe and for children to explore and just be kids. Flexibility was really valued, using different techniques, maybe trying something that we hadn't tried before, looking at different ways of timing rehab and different ways, individual ways, to be able to fit it all in. We heard the importance of exploring, especially different mobility options and equipment beyond what we have traditionally and usually used for children. So, for instance, heard from a family being able to use a different type of all-terrain motorized vehicle instead of a power wheelchair, for say for a child that has ability to walk now, but had difficulty on terrain. We heard especially loud and clear that supporting mental health is extremely important, that this needs to be ongoing. Mental health care needs to be routine and started from the time of diagnosis for both parent, caregiver, and child and youth. That it's really important to support the disability experience. That means being strengths-based and ability-focused, as well as looking at how we can remove things like society barriers. That it's important to give voice, to listen to children to help grow their advocacy skills and their confidence. The things need to be meaningful, especially all those outcome assessments, that we need to record outcomes that really matter to families and to youth. And to streamline, we need to simplify those systems and build communication and collaboration, like Julie was saying, so that parents don't have to be the ones always mediating all of that. A third way of doing that is to embed rehab in life and community. So the first thing is to be activity-based, and this is from a youth voice. Enjoying what I am doing is just as important as what I can actually do when it's done. So the idea being that instead of just focusing on exercises and things, that maybe looking for other ways that you can embed some of those rehab tasks into an activity that you really enjoy. Examples that we heard for things like even playing an instrument or being engaged in an adaptive dance class can be just as a valued way of doing rehab as a strict exercise program. There has to be a balance, though. And talking about balance, it's really important to consider the full developmental needs of children. That includes recognizing that they're more than their physical function, that there's other aspects of their development that need time and support to grow, that children need to learn to be able to explore different interests and activities that they want to try maybe. And I love this last one. This is directly from a quote from a parent, that we need to look at therapy in the wild. So doing rehab activities in community spaces as well as clinical spaces, places like playgrounds and community centers and swimming pools, to be able to support participation in community in the places and spaces that other families and friends are at, and that can support friendships. And finally, we heard about the importance of nurturing SMA communities. This includes building peer connections, for children to build positive identity and friendships, for caregivers to share know-how and to care for each other. Only you as a caregiver know what you're going through. And for therapists to grow knowledge and communication between and among themselves. There's also a collective responsibility to advocate for better access to rehabilitation and medical treatments, and to reduce disability barriers in the world. So over to Julie to summarize some of this.
Thank you, Patricia. The limit of this research is that it doesn't tell us how to find the right balance in rehab or what techniques are the most effective. But what it does tell us is what factors are impacting how rehabilitation is happening right now and what is important to consider. It gives us direction for what is most important to talk about when we're planning rehabilitation together between therapists and families and children, and at a higher system level. It tells us how to start looking at rehabilitation differently.
Thanks, Julie. And from Renelle, we've got some ways of doing this practically.
To help us move forward together in re-envisioning SMA rehab, we have some resources for you. There is an infographic that describes the framework with the fun artwork picture. And there are also 3 types of checklists, one for children and youth, one for caregivers, and one for therapists. These are designed to help you talk about and plan your rehab together so you can remember to include all the factors we heard about in our research. They are available by emailing Muscular Dystrophy Canada at this email address, research@muscle.ca.
Great. Thank you, Renelle. And we're hoping that once you have these, you can print them out and use them freely in your clinical practice, and for families and youth to take them with as you plan things out with your therapist, just so you can consider what's important and making sure you've covered all these different bases. So next steps, over to Serenity.
So our team has been working together for the last 2 years, and that expands far beyond just the patient partners. That's everyone who's been helping Patricia. And we've been full of ideas for the next steps. First, now that there's been access to newborn screening and treatments, it would be great to have a white paper and advocacy to increase rehab services and to make the most of new changes, and to have routine mental health support access to families. Having that routine mental health access is so important because it's everyone who struggles, everyone from therapists to the youth to caregivers, everyone struggles, and making sure that we have that access is so important. Second, we already have multiple communities that exist, but we need to make sure that everyone who wants to be connected, for families, for patients, youth, peer support, therapists, how can we expand to have more access for people to get together for those similar experiences? Third, with more treatments, more kids are turning into adults, and young adults are having an incredibly hard time navigating the system. More often than not, we are just thrown out into the world, and that has become a very large issue. Trying to navigate the system, especially if you're someone who is able to be in the world without a caregiver, trying to navigate that on your own is incredibly difficult. So how can we look at the needs that young adults need to have now? Fourth, we need to have more intervention research, into rehab research, to learn what techniques and strategies work best, because everything is going to be different for everyone. What may work for patient A, F, and I may not work for everybody else. And finally, we need more patient partner projects. I feel as though, because I was able to be such a large contributor to this project, that it was able to give so much more perspective. And that goes without saying for everyone who's helped work on this project. I think it was a great way for us to be able to talk about the things we encounter and struggle with, and really open the mind for those who are doing the research that may not think of these things every day. With research like that, it makes processes more focused on real life patient needs and make it more applicable.
Thank you, Serenity. And I can speak as the therapist, doctoral person on this project, how valuable it was to have patient partners from my perspective. It gave life to this project. And there were many times where there was such a sage word that made me stop and rethink things. Julie, I can I can just, especially your voice of saying, where's the hope, was the impetus for us going back and reanalyzing, coming up with those 4 different factors. And those little bits were so important and gave new life to this research project. It also made the research less lonely, I will say too. It became a
Yeah.
community, and I really
Well,
enjoyed and looked forward to our meetings.
thank you so much for bringing that up too. I just want to let the panel know that when we got the diagnosis of SMA type 2 18 years ago, it was presented to us with no hope. There, it was again, I'm sure people can relate, take him home and love him. And I did a presentation to clinicians and faculty at our pediatric hospital in which I said, well, what else am I going to do? Of course, I'm going to take him home and love him. You've got to give me something more than that. But so that's why I think that hope is so important. And now with these disease modifying treatments, there's real hope for the future for our SMA kids. And this project is absolutely part of that hope.
Lovely. Thanks, Julie. And thank you to all our participants. It was your voices that made this work possible. And we really, huge value, and thank you for your time and contributions to this. We want to thank the children and families who came before. Huge thank you to Muscular Dystrophy Canada for their clinical grant supporting this work. A large part of went to help supporting patient partners involved in this project. And to BC Children's Hospital Research Institute, to the Brain Behavior and Development Program for a trainee grant, and to Cure SMA Canada for their assistance in recruitment especially. And not presenting today, Dr. Jill Zwicker, Dr. Zelby, Dr. Bachman. And I would like to have a special shout out to my physiotherapist colleague, Neve Cushion, who has been such a great support to me and rethinking rehab, and to the SMA clinic team at BC Children's Hospital. You guys are the best. And now we get to throw it open to questions. Just quickly, my email is there if anyone has a question afterwards, and another plug to contact to get a hold of those checklists and materials we developed.
Thank you very much, Patricia, Julie, Serenity, Amneet, for a wonderful webinar and presentation. I do see a number of questions, and we do have time, so perhaps I can go ahead and share it. One piece here is actually not a question, but a comment, which is really happy to see that mental health was included in your presentation today. The other one here is around newborn screening. So getting a diagnosis of spinal muscular atrophy at or near birth is something where mental health and parental mental health is not really of a focus. Did you want to speak to that in terms of, did that come up with the changes in newborn screening?
Yeah, definitely. When I said right from the beginning, it needs to be embedded, we heard that time of diagnosis is a really tricky time for families. Whether that was, children that were born 10 years ago or children that are born just now with newborn screening, it's still a lot to take in. It's a slightly different experience, but there is so much thrown at you with newborn screening as well. So definitely, mental health of almost every participant mentioned that.
The other question is, and this is a common one that we actually get through our research hotline, which is to say, now that there are 3 disease-modifying therapies, have there been studies to look at the combination of a disease-modifying therapy in combination with exercise or rehabilitation programs?
I've already take this one too. No, actually, is the really short answer is there's very little research right now in rehab and what works best. Yeah, there's the research that there is on exercise, strict exercises, actually isn't very strong. And there's different theories that we can look at that, but looking at other childhood populations, When we look at strict exercise programs, they're not usually as effective as we were talking about, as when things are embedded in meaningful activities or when they're really goal focused. When a child gets to choose a really meaningful activity and goal that they want to work towards, that those strategies are usually better. There's an approach as well called motor learning theory, which breaks down tasks as how you learn things. And that has been shown really effective in other populations. So it would be exciting to see if we could try some of those techniques and approaches in SMA rehab to see how that works now that we have all these new potentials.
Wonderful. I know here in Ontario, for example, many families have opted to have intensive rehabilitation following gene replacement therapy, but they often, when making that decision, because it comes with out-of-pocket expenses, wonder, is there evidence behind this? What is the literature? Or even families leaving a certain province to come out here in Ontario for 9 weeks to join these sort of intensive rehabilitation programs. Always seeking the evidence. So to your point, it's not always there, but it is definitely leveraging this framework would be welcomed as part of research. Good. I do see one other question here, which is to say and I think you've addressed this, but with more rehabilitation, more support, more follow-up, more projects, this can become also a burden. It requires time off from work or away from family or away from school. How do you suggest families to reconcile the sort of quote unquote burden of accessing rehabilitation or participating in rehabilitation?
Good question. Julie, Serenity, I don't know if you have any ideas as well before I jump in.
Yeah, no, that's a great question. I can only speak about my lived experience. I didn't juggle those things very well, and I'm still working on that. 18 years later, it's definitely something that needs to be balanced, and I would dare say it's specific to each individual family and how whatever works best for them.
Yeah, it can be a lot. I grew up on a farm. All my treatment was an hour and a half drive one way. So a lot of for my family, a lot of it was I was raised by just a village of my older family members who were retired and had the time to take me to these appointments, and my care team did the best to book around my life and my schedule, but there's really no one solid answer a person can give because it's going to look different for every family, like Julie said.
Yeah. And I think that's that unique approach of really being individual for the family. So really having those intentional discussions about what are your most important goals right now. How can we plan this out a little bit? And we heard from families that having intense bursts, like maybe like I can commit to this for 2 weeks and we're going to like set a goal and we're going to really, a really achievable goal and we're going to work hard towards that for 2 weeks. And then maybe have a month off from rehab so you can balance out some of those other things about your life. And maybe looking at planning that around what work schedule is, when you've got an intense thing at burst at work, or maybe around the school year calendar. Maybe there's like, May and June are really important months for kids. There's a lot going on. There's all those end of year concerts and things. Maybe that's not the time to be doing intense rehab. So that we can let kids and families have a regular life as well, but have times when they can maybe focus on what's really important and making some improvements.
I see a question here from an allied health professional. Can you explain what mental health support would look like? This individual has had a social worker in their clinic, but that's not enough. What would be helpful to families and youth?
Yeah. I honestly think we need to talk to families and youth, which is the best way of doing it. I don't know, Julie or Serenity, if you have any thoughts.
Having public access to mental health services would be greatly appreciated at no cost, and being able to get in a timely manner, and people who are knowledgeable, like therapists who are knowledgeable about caregiver burnout, or other mental health issues that would be most beneficial in my certain circumstances, for sure.
I think also having someone designated to the mental health sector of stuff on teams. Children are usually given a whole team, and it has every little individual person, and so having someone who's dedicated to mental health resources could also make such a big difference. That's another way to make it a bit more accessible.
Julie, this question's for you. You mentioned on today's webinar that your son is now 18 years old. How has that pediatric to adult care transition be when it comes to rehabilitation?
It's been a challenge in so many ways. We're dealing with the transition to the adult healthcare world as well as transition to university. So to be honest with you, it's been seriously overwhelming. Um, a lot of organization, a lot of communication with our teams at the pediatric hospital. It hasn't been smooth, and we're not fully completely transitioned as of yet. But I do know that our pediatric hospital is working very hard on establishing a transition team at both the adult world and the pediatric world. So it is a work in progress, and what I've seen so far, it's been definitely beneficial, but we unfortunately are not going to be able to take advantage of that. Yeah, it's been a challenge for sure. And we're still in it. We're in the thick of it right now, between transportation to university and caregivers to university and meeting new team members in the adult world. We've been with the pediatric hospital for 18 years, and that is our safe place. And now we have to train all new clinicians and doctors all over again. But it's going to happen eventually, and hopefully it will exceed my expectations.
Definitely. This reminds me of another project Muscular Dystrophy Canada funded. Reshma M. and Hernan Gunarowski, Dr. Gunarowski here at the Hospital for Sick Children in Toronto are looking at the transition of teens with SMA to adult clinical settings. And it's important, I'm thinking from a knowledge transfer perspective, really looking at this framework as part of that clinical transition. Holland Bloorview, Dr. Laura McAdam also does an exceptional job. Dr. Kathy Selby, as you know, has a wonderful transition also, but thinking about this framework and integrating it as part of that transition experience is critical.
Absolutely.
Yeah.
There's another question here, which is to say and this is related to teens and young adults, that it becomes difficult for teens and young adults to engage in rehab. It feels boring, monotonous, and now there are these programs, AI-based programs or gaming-based programs. What are your thoughts on those? And is there literature to support those in terms of engaging in SMA rehabilitation?
Not too much yet. I think it's also new, right? AI is new, and SMA rehab is going through a new time too. But I think that came out loud and clear from our older youth involved, is that, yeah, rehab's boring a lot of the time. And I think that has to do with how we haven't been engaging youth and making it meaningful. And, a voice from youth was like, these other activities that I like to do, they are my rehab. So I think it's really flipping it and looking at how you can get benefit out of activities, but not always maybe looking for those extrinsic benefits as well, as just doing activity has value in and of itself, and who you are. Serenity, I don't know if you've got any other thoughts too.
Yeah, I mean, I have a totally different opinion on it because there was just some unfortunate mishappenings when I was transitioning just from care in Calgary to Edmonton, here in Alberta, and then I turned 18 on top of it, and so I haven't received any sort of formal rehab since the pandemic, actually. So well, I can say it's difficult because I've mentioned it a couple times, like, hey, I would like to look at possibly going back to like clinical rehabilitation, it's not easy because now I'm having to be referred, and there's so many different things that happens in different cases, and it's very frustrating.
And my son hasn't had any sort of typical rehabilitation services in probably 10 years. It interferes with the school day and he misses classes. We, as I mentioned earlier, really live by functional therapy. We feel that he gets his rehabilitation through wheelchair soccer. He's actively involved in baseball. He loves to swim. He uses his hands and dexterity and massages. Stress balls. Nothing with any sort of structure per se. Now we do some stretches and just to keep things mobile and make sure that the contractures don't get any worse. But other than that, his rehabilitation is mostly recreational.
Yeah. I think it's rethinking what rehab is sometimes. Maybe you need to brush up with a therapist every once in a while, but we had a great quote from someone saying that, maybe life is better rehab than rehab is life.
Wonderful. On that note, there aren't any other questions, but a lot of comments just saying this is an excellent, study presentation. Families are also saying this is really validating to hear, like the functional rehab, Julie, resonates with a lot of people on the call, because there's also been quite a few mentions here around the cost related to rehabilitation. We've talked about costs in terms of time away from work or time away from school or travel, but also purely the cost per hour for 30-minute sessions to accessing, and that is quite amplified by the adults on the call as well, saying that even when they opted for it without any coverage, it is difficult to pursue formal rehab in that sense. So congratulations to you and the study team for a remarkable project. We're happy to support you on that white paper that was mentioned in terms of next steps and advocating for rethinking about rehabilitation for SMA. But it's such a pleasure for Muscular Dystrophy Canada to support such important work. And as a reminder, please email research@muscle.ca for those checklists, whether you're a healthcare professional, family member, someone impacted by SMA. And I know there's others with other neuromuscular conditions who have already asked for the list. Please reach out. Would be happy to share that with you. And again, thank you all so much.